Hello and welcome back to the channel. Today I'd like to share some insights into the common indications for using long-term anticoagulation in primary care. There are three main indications to use anticoagulation in primary care. The first one is atrial fibrillation. The second one is venous thromboembolism, like deep vein thrombosis or pulmonary embolism, and it can also be used in patients who have had mechanical valves. Atrial fibrillation is probably the most common indication that you'll see. It's an irregular, abnormal rhythm of the heart that can lead to rapid formation of blood clots, which can cause heart attacks or strokes. And in atrial fibrillation, patients might present with palpitations, that's like fluttering feeling in the chest, and they might also have breathlessness, chest tightness, or they are feeling dizzy. When you examine them, you will feel an irregular pulse. Once you've confirmed atrial fibrillation, we use a score system that's called CHA2DS2-VASc score to work out their risk of stroke, and a score of 2 or more means that the benefits likely would outweigh the risks of anticoagulation, and hence we would offer it to those patients. However, this should be decided after a shared care decision making with the patient. Another reason to prescribe anticoagulation is venous thromboembolism. For example, deep venous thrombosis, we can initiate anticoagulation prior to ultrasound confirmation of the diagnosis of DVT. In contrast, when there is a suspicion of pulmonary embolism, patients are preferably referred to the emergency department for confirmation and initiation of anticoagulation. Similarly, anticoagulation for mechanical valves is usually undertaken by secondary care, and patients are then routinely placed on warfarin. Subsequently, monitoring and the titration of this warfarin into the therapeutic range is left to the primary care team. So there are three different classes of anticoagulation that you might prescribe in primary care. One is called a direct
oral anticoagulant.
We often call it DOAC. These are the new drugs like apixaban, rivaroxaban, and edoxaban, and they are the first line choice for a lot of indications that require anticoagulation because they are easier to use than warfarin. Then there's warfarin, which has been around forever. It's a vitamin K antagonist and is still what we use for mechanical valves. The downside is that it needs regular iron arrow monitoring, and you are constantly adjusting the dose of the medication. And then finally, we've got the low molecular weight heparin. You might know this as enoxaparin or clexane, and we can use this in DVT, but in primary care, it's mainly to use as a bridge to provide anticoagulation cover when we're titrating warfarin into range. For each of these indications that I've mentioned so far, there's a guidance on how much to dose the anticoagulation. For atrial fibrillation, if you're starting someone on apixaban, the standard dose is about 5 milligrams twice a day, but you need to consider some other factors. For example, you might want to reduce the dose to 2.5 milligrams twice a day if there's a history of weighing less than 60 kilograms, or if the person is aged more than 80 years old, or if their creatinine levels is above a certain level. For DVT treatment with rivaroxaban, you start them about 15 milligrams twice a day for the first 21 days, then you drop it down to once a day for maintenance. So the different dosing schedules are available, and it depends on what you're treating and which drug that you're using. This is why I always check the BNF. It's got all the dosing schedules there, all the monitoring requirements. I don't try to memorize them because I've learned where to look and check them up quickly if I'm stuck. So before you start anyone on anticoagulation, you need to regularly check that it's the right dose you're prescribing, and they might also need some prior blood tests and renal function, especially if it's for the DOACs, because these drugs are excreted in the kidney. So if someone has got a kidney problem, you might want to adjust the dose. And you also need to check the liver function because of the effects that they might have on the liver. You might also want to get a full blood count to see the baseline, particularly if you're worried about bleeding later on. So always check other drug interactions. Anticoagulants interact with so many other drugs like non-steroidal anti-inflammatory drugs like ibuprofen or naproxen, and also certain antibiotics also affects the way warfarin works. So always check out to see what the patient is taking before you can go ahead and prescribe these drugs. I hope this gives you some confidence to approach prescribing anticoagulation in primary care. Let me know in the comment section how you approach anticoagulation in your practice. Thanks for watching, and I'll see you in the next video.